As we come to the end of 2024, and I try and anticipate what is likely to happen next in terms of the COVID pandemic and the outcomes in terms of disease, I realize that people want solutions. They have heard enough about the problems. And over the past few years, I've been predicting a lot of issues, especially around vasculitis, autoimmunity. And the question is, how can we identify who is going to be affected? And if so, can we do anything about it? So I'm Dr. Philip McMillan, and as I said, I've been focused on autoimmunity in COVID since early 2020. There's no pleasure in being right about many of the things that had been predicted, but critically, trying to move ahead of the science again, I'm looking forward beyond where we are. Now, you have to understand whenever I speak about autoimmunity, I am focused on the spike protein. It doesn't matter the source. Wherever it comes from, there is the potential for this to occur. That's just based on what we have seen. And so now I'm going to take you through a couple of ideas or concepts that are important with regards to this autoimmunity question. Before I start, as usual, remember to join us with regards to our Disease X Are You Prepared? This is our book on Amazon. We're still number one in viral diseases. If you support us, really good book. We're going to break this down some more, giving you some of the stories. Just really help us to keep it up there. And it is great reading. The stories that are involved in this are quite remarkable and help you to understand a bit more about the science. So it's a culmination of many years of thought and research into a story-based and science-backed document that will help the general public to be able to understand a lot more about being prepared for viral diseases. So let's get to the challenge and the issue about vasculitis. As usual, let's just use, I'm going to use John Hopkins in this case to try and give you some ideas about what is vasculitis. So this is from the John Hopkins Vasculitis Center, and they describe vasculitis as a condition characterized by inflammation focused in the wall of blood vessels. And you can see here, this is an intact blood vessel. These are red blood cells floating in the middle. This is normal. And then you have down here an inflamed blood vessel. And in this case, you can see that the wall is thickened. And you have in this image here showing a lot of immune cells focused in the wall, which causes it to become inflamed, increases the risk of clots, and damages the blood flow. So there are a number of things that happen because of vasculitis. And this whole process is what I am concerned about in the context of the ongoing pandemic. I've been talking about the COVID storm. And the COVID storm is where we have a culmination of two things. And this is in relation to ongoing circulating infection with the spike protein, triggering autoimmune responses in people who are already vulnerable because autoimmunity has been triggered before. And I describe the spike protein almost, this COVID storm almost like an epoxy. You have the infection here, you have the immune priming on the other side. The two together cause this storm. This storm, as I reflect more and more, is likely to present more as a vasculitis. And the problem with a vasculitis, as with all autoimmune conditions, is that they are very, very difficult to identify. And so I'm going to bring some of the science in here to help you to understand the complexity of it and also to help you to see why this is so important. Before I go into the science, though, I have to remember a very specific case that we had covered. And I did an interview on this. This is with regards to the Unstoppable Mothers Against COVID-19. And in this here, Hetty Simoes and Heather Hudson both were speaking with Dr. Balbona with regards to her son who lost his life and the work that they had done. sadly, this interview was censored. It was an incredible interview, and I'm going to play a clip of it so that you understand why she, as a mother, pushed so hard to find solutions with regards to her son. And what you have to realize is that in that case that she was talking about, she pushed it as far as to get his samples sent across to Germany, examined carefully, to demonstrate that his cause of death was related to a single dose that he had of the vaccine. It's sad that it was censored because this was pretty clearly demonstrated in terms of the autopsy evidence that they had put forward. But just before I explain the vasculitis, I thought it was important to just share this case and remember what Hetty had said. So I'm going to play a short clip about her personal feeling about it and let you know then what happened in terms of Victor losing his life with regards to theoretically what would have been a vasculitis of one of the large blood vessels. Actually, before I play Hetty's clip, I think it's important to see just exactly what it is that they're talking about with regards to what happened in his case. And so if I show you here, this is just a picture of the arteries. This is the heart in the middle. This here is the arch of the aorta. It goes up, then it comes down, sends off some branches to the head. Everywhere that's red is the artery. Everywhere that's blue are the veins. And so what we're specifically interested in is the artery in this case. And in his case, he had what was an aortic dissection. So this is a normal artery here. And you can see this is the blood in the middle. This is the lining, the elastic lining of the inside, elastic lining on the outside, lots of muscle cells. And in an aortic dissection, what happens is that it rips through this elastic lining, which normally is very strong, and then blood, because of the pressure, then leaks down through the lining and the muscles of this blood vessel. And potentially, why it's so serious is that it can break through this and cause significant bleeding. And this is essentially what it looks like in a vein as well with regards to the vasa vasorum. So this is an important piece of information that has occurred. And in his case, he ended up with what we call a large vessel vasculitis involving the vasa vasorum, which are the lining blood vessels which supply the oxygen and energy and nutrients to all of the muscles. So when these become inflamed, it causes inflammation in the muscle and the elastic medium, and it can cause it to break down because it gets weaker. And in his case, this is what would have caused this artery to rupture. And so it was a very important case. And as I said, it was sad that this case didn't get the attention that it needed to. It's sad that it was censored. And she, because she is his mother, she lost him. He was only in his 30s. She represents an important voice for advocating for those losses because every life is significant. Listen to what she had to say, a short clip from the interview. And if you want to watch the full interview, I'd recommend it. The link is in the description below. But hear what she had to say.
You may hear occasionally of a young man having an aortic dissection, but almost 100% of the time it's because afterwards they do find there's a genetic link. Victor did not have a genetic link. So that, and also another point that I did specifically ask the coroner if he had had an aneurysm, because that and he did not. And he also said that there was no evidence of high blood pressure in his heart. So it was like, and when I showed his all this information to cardiac specialists and aortic specialists, they basically said that if he had walked into their office the day before, they would have given him a clean bill of health. Mm-hmm. So this is a tragedy that I lost my son when he could have been here had he not taken the vaccine. Do you know how angry that makes me? And I'm not going to speak much more about that, but you can imagine, to lose a child is a nightmare, but then to know it was because he did something that he was told was safe, and now he's gone, and my life, my children's lives, we're going to feel this effect for the rest of our lives. I won't have his grandchildren. I won't have his, grandchildren. His brother and sister, they were dreaming of all having children together and their cousins playing together because they were all at that age. This has ripple effects that people don't understand when you lose a person that you love. And to lose a person in this manner, it's very hard for me to process.
That was a very, very important and heartfelt statement by a mother who lost her son. And some people may say, well, it's just, one of those rare things that occur and she was just unlucky. Well, I think that it's far more complex than that. He was unlucky, yes, in that he had a severe outcome. But I think the more that we look at things and we reflect on things, that this is probably not as uncommon as we think. And as I said, it's largely because vasculitis and inflammatory diseases are quite difficult to diagnose, and it takes a long time to make them. And so I then went back to the literature to try and understand as I predict what is likely to happen, because that's the first thing you have to do. You have to think, okay, if this occurs, how can we mitigate it? And that's really where the question lies about the mitigation strategies. So here we have a paper that's very important in terms of small vessel vasculitis after vaccination. Now, it may seem that I'm targeting this. It's not that, because this can happen both after infection and vaccination. I just think that we have a higher risk when we have a combination in people who are vulnerable. And this is a really important point. And I tell you why it's such an important point. People don't quite understand. In someone who has natural immunity or has good levels of mucosal immunity, because it can also occur in people who are vaccinated that they have good mucosal immunity. But it does seem that there's an increased propensity for infection in vaccinated cohorts when we look at population statistics. And whether or not it's happening across the world, people may argue that in low vaccine regions, they're not testing. The point is that we do know that in highly vaccinated regions, there is high ongoing circulation of the virus. And as I said with the COVID storm, if the immune system had been primed before and then has exposure, re-exposure after re-exposure to the virus, my anticipation would therefore be, or the scientific extrapolation would be therefore, that the risk in the longer term at a population level will be higher. How long it takes to manifest is very difficult to know. And so for people who were right on the brink or had low level autoimmunity, it's quite possible that they could then have this unmasked, even by an infection or in some cases by a vaccination. So it's really important to differentiate that very often it's an unmasking of autoimmunity, not necessarily that the vaccine had triggered autoimmunity. And so this was the case, as I said, that was published from Poland. So they have no skin in the game. They're just looking at the science. And this was published in May of 2024. And they were looking specifically at ANCA, which is anti-neutrophil cytoplasmic autoantibodies vasculitis, that was occurring after COVID vaccines in case reports. So, what tends to happen is that if clinicians are starting to see unusual patterns, they will make a case report because, wow, I've not seen this before. So, they then write up a case report and then they publish it. Now, in this case, they looked at a total of 404 articles. And of those articles, here you can see they found 34 papers that fulfilled the inclusion criteria. And they then looked at 44 patients with new onset ANCA autoimmune associated vasculitis after COVID vaccination. So someone may look at this and say, well, only 44 patients were affected. That's no big deal. Well, you have to remember that in reality, the 44 case reports, that doesn't mean only 44 people were affected, because if somebody in the region sees somebody who's already done a case report on it, they won't bother to do a case report because it's already been done. So those 44 case reports can reflect thousands, tens of thousands of cases that are being seen, but not necessarily being associated. And so it's a really, really important factor to consider. Now, when I think about, and this is the part that I'm trying to work out, when I work out where is affected in terms of this, I think that that's where the clues are for trying to identify patterns. So this is again a breakdown of the table in terms of the papers. This is the authors. These are the number of cases here going down to 44, and they have their age, they have the gender, and they have the comorbidities. The first thing that stood out to me was that of these 44 cases, where you see a blank, 21 of them had no comorbidities. Now, some of them had comorbidities, and you could say, okay, this possibly was part of the picture, but 21 of them had absolutely no comorbidities and still ended up with this autoimmune pattern. So that's the first thing that I noticed with regards to the symptoms and the presentation. The second thing that I noticed in this case is that it's difficult for you to see here, but again, it's the same 44. They looked here at their symptoms here and which organ was affected in terms of respiratory. But when they looked at the urinary symptoms or urinary system here, wherever you see renal impairment, increased creatinine level, this is the vast majority of the 44. And in fact, edema, swelling of the legs, and renal impairment, they all are connected. Only one, two, three, four, five, six, seven, eight of the 44 didn't seem to have involvement of the kidneys. So this is now a really important red flag in the sense that I now realize that, okay, what we need to be watching are people's urine and creatinine or their renal function. And so you can then help people to know that they need to make sure they've got a baseline blood test looking at their renal function to try and make sure that in case anything like this happened, this could then be identified more easily. The other thing that this paper demonstrated is that when they looked again at when they looked at new onset vasculitis and they looked at the diagnostics and the biopsy findings. Now, this is really critical. You can see that heart is involved here. Mention one, there's skin, nasal mucosa. Biopsy was not performed on that one. But kidney, 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 kidney. And you suddenly realize that in most of these cases, they had kidney involvement based on the biopsy. So they had immune crescenteric glomerulonephritis through a significant proportion of these cases. So again, that gives me an idea that actually, when you think about it, you are likely now to be seeing kidney involvement as the most significant factor to identify if something is happening or if something is going on. And again, breaking down the paper into some more detail, because again, these things are quite valuable to reflect on. I'm going to show you now about in terms of the characteristics of the patients here. You can see in this here, in terms of their gender, 61% were female, 38.6 were male. Now, this tends to follow generally autoimmune diseases. Women tend to be more affected than men. When they looked at the vaccines, we can see here that Pfizer was 56.8, Moderna was 20.5, 11.4 was Oxford AstraZeneca, and then another 11.4 were others. So if we take out these technically 23%, it means that 77% of all the cases were related to mRNA vaccines. Now, this may be just because more of them were given. However, it could indicate that there is a predisposition for this to occur. So that should be investigated a little bit more closely. Again, when we look at the triggering of these responses, the majority happened after the first dose. Now, this is one of the reasons, and think about this. First dose was 56.8, second was 31.8, and third was 11.4. Now, this is a really important point because when I had looked at the mortality statistics, I had found that there was apparently a flag in terms of people who had only one dose of the vaccine. It just appeared that, and I hoped public health would have picked up on it. Because the question is if you took one dose, why would you not have taken the second dose? Because you would have known you weren't fully vaccinated until you had both doses. So it could indicate that the people who only had one dose, a proportion of them, not necessarily all of them, but a proportion of them may have had such significant side effects or adverse effects related to it that they did not go on to have another dose. Now, the same thing could be presumed because, again, if you then look at the two doses together, first dose and second dose, if you put those together, because the third dose was only 11.4%, so you're talking here about almost 89% of these cases occurred up to after the second dose. So again, we may see a pattern where there are a number of people who didn't accept the booster doses, and that may be because, again, they had adverse effects and therefore didn't go on to have any more of the vaccine. So part of vaccine hesitancy, what should be being checked out is whether or not adverse effects were so significant that people refused to have any further dosing. And a really important point to consider. Again, another point from the data here was the timing. So, in terms of symptoms development time, 31% were within a week, within 2 weeks, 29%, 3 or more weeks, 25%, and unspecified, 13.6%. Now, this bit here is really important. So when you put unspecified 13.6 plus 25, you're getting over 40% of them are 3 or more weeks after the vaccine. The reason that's important is because if you are not doing active surveillance, and you are not actively looking for problems, the patient and the doctor may not make the association because the time frame is not that close. The person may not even have remembered that 3 weeks ago they had their COVID jab because remarkably, patients don't even think about it. And so therefore they don't tell the doctor. The doctor then doesn't make the association because he hasn't necessarily looked to see if there was a close connection, and this then gets missed. And so that's important because it could indicate that if 40% are after 3 weeks, that was because people were quite diligent. And if we were looking actively, that number could be significantly higher in that context. So these are really important points. Another point that the paper highlighted here was to do in terms of which systems were involved. Digestive system, not so much. So this is in terms of percentage here. The standout, again, as I said, was the kidney, urinary system, up to 35%. And again, this is oftentimes picked up because people have blood works. Routine blood works often involve their creatinine. And so if that's elevated, it's a flag. Inflammatory patterns, so things like their CRP and ESR, could be up and it triggers a clue. You have muscle, nervous, respiratory, not as high. I think those are much more subtle. But the standout ones here are to do with the urinary system and the inflammatory system. Now, people may think as well that, well, so what if people are getting some mild triggers of autoimmunity? This will just settle down. No, the reason this is so important to identify is that if you don't address it, you have ongoing inflammatory changes, which will then potentially cause permanent end organ damage. And In all of these cases here, what it demonstrates is that almost every single one of them had some form of treatment. You can see here the azathioprine and the cyclophosphamide. These are immunosuppressants. Some up to almost 14% needed dialysis. Some needed monoclonal antibodies. Some needed plasma exchange, rituximab as well. And so you have a clear here that almost every one of them required treatment. This is exactly the point. If the identification of the condition is not made and no treatment is done, you then can have a situation where you have long term damage occurring, especially based on this case in terms of the kidneys. So, the problem we've had now is that after the rollout, we're over 14 billion doses. The virus is still circulating. The reality is that what I would say for those people who are very strongly pro. Now, let me make it clear to my audience. I have no particular narrative in my head. I'm just looking at the science. So I recently was speaking about some of the benefits that can occur with the mRNA vaccines, and people are saying there can be no benefit. I'm thinking this is science. You can't use it if there were absolutely no benefits. Of course, there were benefits. The question was whether or not the benefits outweighed the risk, and which cohorts would you have most appropriate for that risk benefit analysis. So I don't have a narrative on this. I know exactly where the benefits are in terms of the mRNA vaccines and COVID vaccines generally. So I don't take the position that there were no benefits. I think that's not a reasonable position. However, I do say that in the context of when it's used broadly across a population, I think that there are risks to specific cohorts who may not have been at risk for severe disease. That's my perspective in terms of the balance. And so when we look at where we are now, we still have to acknowledge that the vaccine had an impact on severe COVID 19. It doesn't necessarily mean that it had an impact on all cause mortality. And so that's why I am focused on excess deaths, because if it impacted all cause mortality, I would expect overall excess deaths in highly vaccinated regions to be significantly lower than they are now. And that indicates that there are problems. And part of the problem is probably that is driving autoimmune responses. This is accelerating disease for specific cohorts, often who have comorbidities, and this is driving the excess deaths across highly vaccinated regions. That's my perspective. At this point, it really doesn't matter too much what camp you're in. What matters is that we figure out who could be affected, how they can be affected, and how we can mitigate disease presentation. So just remember, don't get too much in terms of the politics. Don't get too caught up either in who was right and who was wrong. At this point, we still have serious problems ahead where people are getting sick because of the fact that the virus is circulating, and it can potentially affect anyone. But yes, there are some cohorts who can be more seriously affected than others. So that's the challenge that I have for the year to come. As I said, I'm focused on the science, trying to pick out what works, what doesn't work, why does it work, why doesn't it work, and what can we do, especially because there doesn't seem to be much guidance coming to the public. So, in conclusion, remember, join me in this journey, Disease X. Are you prepared? Because if you read it, you'll understand more about what it is I'm talking about. Because in there, I try and be as balanced as I can be about where there were benefits, where there were risks, what was right, what was wrong, and hopefully give us a better understanding for the future. So, thank you for staying with me. Have a great evening. Look forward to talking to you again soon.